Shruti Dayal. She will be speaking on dry eyes and glaucoma, a challenge compounded. It's a really, double trouble for the eyes nowadays with the development of glaucoma, medications, and dry eye.
Respected sir and dear colleagues, today I am going to discuss on the topic dry eyes and glaucoma, a challenge compounded. We all know that glaucoma is a chronic sight-threatening disease, and early diagnosis, ongoing treatment for long duration, and treatment adherence are critical to slow down the disease progression and prevent blindness. But when it is associated with dry eye disease, it really affects the quality of life. It has been seen that both of them often coexist, maybe because of the age-dependent prevalence. Both of them are more prevalent in older age. Dry eye disease affects about 40 to 59% of glaucoma patients. Both are associated with mood disorders, depression, anxiety, and when they coexist, they are really a public health burden. The patient of glaucoma, when it has dry eye disease, he complains of burning, stinging, pain, irritation, redness, and it impacts the daily activities. There is decrease in visual quality because it generates aberrations and causes irregular astigmatism and worsens the contrast sensitivity. It affects the reliability of perimetry in glaucoma patients. The poor adherence on the anti-glaucoma medication further worsens glaucoma. So early diagnosis and management is very necessary in patients of glaucoma. Ocular surface disease index shows that ocular surface staining was more prevalent in glaucoma patients as compared to controls. Tear breakup time was shorter, Schirmer's scores were lower, tear osmolarity was affected, conjunctival hyperemia, eyelid abnormality, meibomian gland dysfunction, and conjunctival hyperemia has been seen. Many case reports in the OPDs are being found. In each of us OPD, we find that patients on anti-glaucoma medications for a long time, they develop irritation, itching, redness persistently. Then meibomian gland disease and dysfunctions are being seen in the patients of glaucoma. Periorbital dermatitis is seen in patients of glaucoma who are on anti-glaucoma medications. Then back-induced acute allergic reactions and mild chronic blepharitis has also been seen because of long-term anti-glaucoma medications. So why dry eyes occur in patients of glaucoma? It may be because both dry eyes and glaucoma are coexistence because of the age factor. Another, glaucoma medications themselves as well as the preservatives in the glaucoma medications affect the ocular surface. Ocular surgeries also affect and modify the ocular surface responsible for dry eyes. The pathophysiology of dry eye disease in glaucoma is multifactorial. It causes a self-perpetuating vicious cycle caused by risk factors of dry eye disease and glaucoma, which are responsible for a combination of tear film abnormalities and instability, resulting in release of inflammatory cytokines and mediators, altering the quality of tear, reducing the reflex lacrimation, and thus ocular surface drug concentration increases. And this further increases the tear film instability. Anti-glaucoma medications, they have an inflammatory effect on the tear film, reducing the production of tear film. They have effect because of the preservatives and excipients, which will disrupt the corneal epithelium and reduce the corneal sensitivity. The chronic use and the number of daily drops put in the eye every day, they have been shown to be causing goblet cell loss and dysfunction, meibomian gland dysfunction, pseudopemphigoid reactions as well, and cicatricial conjunctival changes. The preservative, especially benzalkonium chloride, is the main culprit, has been found to be added into the preparations because of superior antimicrobial effectiveness, but it negatively affects and impairs the corneal sensitivity. Ocular surgeries also modify the ocular surface, like trabeculectomy has been reported to cause corneal epitheliopathhy, filamentary keratitis, and Dayal formation. So a patient of glaucoma, if has a pre-existing dry eye disease or develops dry eye disease on anti-glaucoma medications, then should be treated as early as possible. Ocular surface inflammation may manifest as early as 3 months after the initiation of anti-glaucoma therapy. So a detailed medical history of the patient should be taken in order to find out the other risk factors which may be responsible for this. A detailed clinical evaluation of the patient, each and every patient of glaucoma should be done in OPDs through tear film assessment by Schirmer's test, tear meniscometry, tear film osmolarity, tear meniscus height. Then fluorescent tear breakup time should be assessed, and it helps in assessing the degree of aqueous deficiency. The non-invasive tear breakup time also through keratograph, placidodisc, keratometer has been found to be worse in glaucoma patients. Ocular surface staining helps in grading the degree of dryness in the patient's eye. Then conjunctival hyperemia has been related to number of glaucoma drops put in the eyes. Pseudopemphigoid has been found to be reported in patients under long-term glaucoma medications. Meibography also has been found to be worsened in patients with glaucoma. Metallomatrix metalloproteinase inflammatory biomarker, which is a commercially diagnostic device, has been found to be increased levels in patients who are on back-preserved glaucoma eye drops. So management of dry eyes in glaucoma is a challenge. Long-term treatment plans for both glaucoma and dry eye disease is challenging, and each and every patient should be considered individually. Ocular surface status of each patient should be evaluated regularly as a part of routine follow-up of glaucoma assessment to ensure timely detection and treatment, especially when we start a new topical therapy. The main hallmark of management should be to minimize and modulate ocular surface inflammatory response. So the guiding principles of the treatment will be to minimize the effect of glaucoma therapy on ocular surface and to recognize and treat dry eye disease as early as possible in management course. So we go ahead with either of the options. It depends upon the fact that what is the severity of dry eye disease, what is the stage of glaucoma, and what are the therapies which are available to us. In modification of glaucoma management, we should minimize the use of preserved topical medications, and use of preservative-free anti-glaucoma medication should be encouraged. Combination topical anti-glaucoma medicines helps in reducing the number of drops placed in the eye. Switching active component of anti-glaucoma eye drop may be useful as patient may be allergic or sensitive to specific component of the medication. Innovative drug delivery systems are also being made available. Bimatoprost ocular insert, latanoprost eluting contact lenses, latanoprost punctum plugs, they are also being made available. Selective laser trabeculoplasty may be considered more frequently in mild glaucoma patients with similar efficacy and decreased cost than the topical anti-glaucoma medicines. Sustained control of IOP by cataract surgery may be considered in patients with cataract surgery and cataract and glaucoma and dry eye disease. MIGS alone or in conjunction with cataract surgery may help in reducing the reliance on topical anti-glaucoma drops. Role of trabeculectomy is controversial, should be avoided. Then treatment of dry eye disease. Rigorous treatment of ocular surface disease with preservative-free lubricants, especially preservative-free hypotonic formulations of hyaluronic acid, teholose, taurine increase the conjunctival goblet cell density. Ocular surface immunomodulators like cyclosporine, they minimize the long-term chronic changes on the ocular surface. Taurine, an amino acid present in the tear film, it exerts protective role against oxidative changes to ocular surface. Autologous serum 20% helpful in managing toxic ophthalmopathy. Punctum plugs, topical palmitol ethanolamide are other aspects. Then treatment of meibomian gland disease should be considered in patients because 80% of glaucoma patients may develop this. Warm compresses, pulse light therapy, thermal vector pulsations with meibomian gland expression. So the take-home message is glaucoma is a chronic sight-threatening disease and it demands lifetime management. So managing coexisting dry eyes and restricting the negative impact of chronic use of topical anti-glaucoma medication on ocular surface homeostasis is essential to get best visual outcomes, quality of life, and patient satisfaction. Thank you.